Good afternoon, everybody. My name is Larry Hoffheimer, and I am the chairman and founder of the Macular Degeneration Association. We are pleased to present these educational conferences to people with macular degeneration and other low vision issues. And we have today a very prominent speaker that's going to present on vision rehabilitation. Before that, I'll tell you a little bit about the Macular Degeneration Association. We are a not-for-profit voluntary health agency that focuses primarily on educating patients with vision issues, primarily AMD, on how to best seek treatment and what some of the questions are that your provider may not have the time to give to you. So I want to also thank three of our sponsors, Regeneron Pharmaceuticals, Novartis Pharmaceutical, and Nodal Vision for their support for these programs. The Macular Degeneration Association was founded by myself after I learned that my mother had wet macular degeneration about 20 years ago. There was very little she could do, and she did lose her entire central vision. So I felt it was very important, having gone through that with her, I wanted to do something to educate patients. I'm actually a retired healthcare attorney from Washington, D.C., and I work with a lot of patient organizations, and I wanted to do this for AMD. As luck would have it, as many people know, macular degeneration does have a genetic component. And because my mother had it, or as a result, I ended up getting wet macular degeneration about 3 years ago. I caught it very quickly and did not suffer any vision loss. So I was very fortunate, but I do get the eye injections. All that being said, I want to remind you to hold your questions under the Q&A tab at the bottom of the page. And our speaker is going to read those questions at the appropriate time. In the meantime, I'd like to introduce our guest speaker, Dr. Thomas Porter, who received his degree of optometry from Southern College of Optometry in Memphis, Tennessee. He completed his fellowship at the New York Lighthouse. Dr. Porter is a diplomat of the American Board of Optometry, and he's assistant professor and director for low vision services at St. Louis University Eye Institute. His practice is at the Center for Specialized Medicine in St. Louis. It's now my pleasure to introduce to you Dr. Porter. Dr. Porter, take it away. He's muted.
Okay, have you got me now? Larry?
Yeah.
Okay, I expected a much older man when you were describing me. Thanks everybody for tuning in today. We had some minor technical difficulties. I've got a PowerPoint, but unfortunately you can't see it. So the title of what I thought of was, Now What Do I Do? And I encourage all of you to seek the very best medical care you can find, but what else can I do? What do we do if something can't be fixed? So that's kind of what I'm going to go over today. And my screen, there we go. I'm going to give you a little financial disclosure. I'm a consultant to one of the companies that makes low vision aids, but the materials that I put together, I did independently with no commercial bias, and I don't think that I've used any of their products just for an example, but if I did, there are many, many manufacturers that make similar products. So I know that the real interest in your group is macular degeneration, but I want to paint the picture of how big the coming storm is in macular degeneration. AARP tells us that 10,000 Americans turn 65 every single day. I'm a baby boomer, and I was in that group that turned 65 one day. There's a center called the Pew Center, and it estimates that 30% of the US population will be over 65 in about the next 10 years. It's been estimated that 37 million people here in North America fall into what I call the low vision category. And using the Pew Institute's numbers, that's probably going to double in the next 15 years. The causes of low vision in the US have been gradually shifting and changing. In my own clinic, I'll give you some ideas here. We think about vision loss as being profound, legally blind, things like that. But the reality is one starts to suffer a loss of safety and independence in their daily living when the visual acuity falls just below 20/50. And the reality is in most states, people at 20/50 are still able to legally drive. So I've got a graph in front of me, I wish you could see it, of the pathology that we encounter in my low vision clinic for the last 5 years. And over 65% of the patients that I'm seeing have age-related macular degeneration. And then a big percentage are diabetics too. And I think the diabetics are going to give us a big run for our money in the future, because diabetes is almost like an epidemic in the US. And then a big portion of glaucoma. So AMD is the big one, the big cause of vision loss that I see. Diabetes second, glaucoma third. And I think about, as I try and put these things in perspective for me, I think about the movie The Perfect Storm. If any of you remember that movie, it was these 3 massive hurricanes that came together and formed this perfect storm. And what we're facing, as from my perspective as a low vision provider, and really as a country, the demographics predict that there's going to be a tremendous increase in our low vision population. And in medicine, we always think about cures, you know, the cure for the cold, the cure for flu, things like that. If you remember what I just said, I said AMD, diabetes, and glaucoma. And at this point in our medical history, we don't have a way to cure it. We don't have a way to fix it. Research is the dollars are not wasted, but right now, in the best case, in each of these things is catch it early and keep it from progressing. So that's the second ingredient of my perfect storm. And the third one is, unfortunately, the general public doesn't get much guidance on what their options might be as they notice this decline in vision. So where do you start? Where do we start as a team? And honest to goodness, as I review what I do, the low vision exam in my clinic starts before you ever come to my clinic. We have a member of my team that triages, that has an interview with you over the telephone before. And we ask the patient to be very specific about the problems their vision loss is causing. And we want to help you establish what we call visual goals before you ever show up. A visual goal isn't, I just want to see better. I can't measure whether I'm helping you with that. But if you said, all I want to be able to do is read my mail, at the end of an exam, I can either show you you can do it or you can't do it one way or another. So I'm encouraging you as you go forward and you seek care from a low vision provider that you set very, very, very specific visual goals. Don't be afraid to set your goals by priority. If I could help you with just one thing, what would that be? Because then I don't waste a lot of time, and I don't waste your time trying to do things that aren't important to you. The second thing that you want to keep in mind as you start setting these tasks is, what's the duration of your goal task? If that patient comes to me and says, I want to read my mail, that's fine. If they say, I want to read the book War and Peace again, that's a totally different goal, requiring just a whole different set of probably different equipment or something like that. So priority is incredibly important. Otherwise, if you leave it up to me, I may not understand what's most important to you. The second thing, again, is the duration. Then the third thing is what I call the working distance. Is there some reason that you have to hold or do a task at a certain distance? because that enters into how you and I are going to work together to try and solve your problem. We all have to keep in mind any special challenges that you might have. For instance, just before we tried to link up today, my patient had Parkinson's, and holding anything close to the face increased the tremor. So that's another thing that your low vision provider needs to know. I think in the simplest sense, when I'm trying to help someone with vision loss, there's really only three basic variables that I have to consider and work with. The first one is what we call enhancing contrast and controlling glare. And I'll go over that just a bit with you, but this is a variable that we work with. The second thing is, no matter what I do, I can't make things sharper, crisper, clearer, but I can certainly magnify things. And then the final thing is you. You have to actually modify your behavior and be willing to do things a different way than you once did. And of those three variables, guess which is the hardest one? Change, doing things a different way. So I'm going to talk about contrast loss because it's probably the most overlooked variable that you can use to help yourself. Some of these things you can actually do on your own without my guidance. In layman's terms, contrast is your eye's ability to visually separate what you're trying to see from the background. A normally sighted person on a foggy day wouldn't call their eye doctor and say, oh my gosh, today's a blurry day. That would be contrast loss. Contrast loss is almost 100% in vision loss. Now, I'm not talking about glasses. I'm not talking about the normal refractive errors, but if a person has age-related macular degeneration, wet or dry, if they've got glaucoma, if they've got diabetes, if they've had trauma to the eye, in the normal aging process, we lose them. But contrast loss is almost universal. There's not a single sight robbing pathology that does not diminish contrast loss to some degree. Patients will describe their vision to me not as blurry, but my vision's hazy, my vision's cloudy, my vision's foggy. Unfortunately, many of my colleagues that haven't thought this thing through think blurry. So they put you in front of the eye chart. No, it's no worse. You're still reading the 20/40 line or whatever it was that you did at the last visit. However, if you lost contrast sensitivity, that does not show up on the standard eye chart. The common complaints that I hear in my clinic, and I'm sure if I could see all of you, you'd be nodding your head yes. One of the most common is I have difficulty identifying facial features across a room or further away. I go to church and people wave to me and I don't know who they are because I can't identify. Another one is navigating steps. How far to step off a curb. Reading newsprint obviously is one. Newspapers no longer are white and the print's not black. So that's a difficult thing. And even seeing food on a plate. If you think about it, a meal of turkey breast and mashed potatoes and cauliflower on a white plate, on a white tablecloth in a dim restaurant is, you can't see it. So contrast sensitivity loss is universal. If you've got AMD out there, you have some degree of it. And there are things that you can do to help it. There are some questions that we ask in our history and in our intake of our patients. Do you have problems seeing faces across the room? Does glare bother you? Because there's sort of a fine line between contrast loss and glare sensitivity, and they shouldn't be confused. I'll talk about that in a minute too. We always ask, do you wear sunglasses? What color do you prefer? And do you like dark or lighter tints? And that gives me a little bit of information about how much the glare is the issue. This is a key question. Do you feel like you have to remove your sunglasses when you get into a shady area? And that's just one more indication to me and to you that you have a contrast loss. You have trouble navigating stairs and curbs, as I mentioned before. And does glare from the sides bother you? Do hats help? Now, there are three basic ways to enhance contrast. And two of the three are pretty straightforward, and you can certainly incorporate this in your daily life. The first one is lighting. Studies show that people with macular degeneration, beyond the very, very earliest stage, require anywhere from 3 to 10 times better lighting than a normally sighted individual. All lighting is not the same. If you really pay attention, lighting has a temperature. It can go from white, 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 like a lot of these LED lights, to a yellowish light. That's one variable in lighting. The other is the intensity. Is it a bright light or a dim light? And there are light fixtures made that allow you to adjust both of those things. Because we're a big low vision clinic, manufacturers will bring in prototypes of things they're considering manufacturing, and they want us to try it and give them some feedback. And we had a light that did exactly what I'm describing to you. And the interesting thing was all AMD patients didn't adjust it the same way. All diabetics didn't. All normally sighted people did. So it's a very, very special thing, but don't overlook lighting. It's a cheap way to help yourself. If you wonder if I'm giving you a straight story, on a nice, bright, sunny morning, go to a window where the sun's coming in the window, take something that you like to read, and go to that window, have the light from the sunlight shine on what you're trying to read, try and read it, and then immediately go back to that easy chair where you read in the evening, turn the lights on, and see if it's more difficult. If it is, you don't need me to tell you, you need better lighting. The second thing is a little bit vague, but it'll make sense in a minute. It's called the figure-ground relationship. And the more different two objects are in color, the easier they are to see. Why do you think doctors use a black on white eye chart? Because that's 100% contrast. 100% contrast is the easiest to see. But if you think about the real world, there aren't a lot of 100% contrast things. You know, let's make a list. We've got eye charts and Dalmatians and penguins and Jesuit priests. I mean, the list is very, very low. But if you modify the figure-ground relationship, you can do better. As an example, if you're sorting medication out, do it on a black napkin, not a white napkin. The whiter the paper and the blacker the ink or the felt tip marker, the easier it is for you to see. So get away from the blue ballpoint on the blue checks. Food on a plate. I found on the internet, I was just doing some surfing, and I found a manufacturer that makes a dinner plate where one half is black, one half is white, with the idea that you put the spinach on the white side and you put the mashed potatoes on the black side. So don't overlook lighting and figure-ground relationship. And let's see, my computer's not cooperating. Then the appropriately tinted lenses. Certain lens colors enhance contrast. Certain lens colors decrease contrast. So appropriately tinted lenses, and I'll try and give you some guidance in just a minute, really can make a big difference in how you function. Contrast enhancing lenses typically range from yellow, school bus yellow, through the oranges and the dark ambers. Did you hear? I didn't say gray, I didn't say green. Sometimes we'll use plum and even red, but rarely gray, because a gray lens, while it cuts glare across the spectrum, it also decreases contrast in some of those really critical areas for you. Remember, too much light creates glare. We all know about glare. Glare hurts. But there's more than one kind of glare. Glare certainly can affect your function. Reflected glare is the one we're all used to. You know, you go to Treasure Island, Florida, and at the sunset, the sun is reflecting off the Gulf, and it hurts. You put on your polarized sunglasses, and it's much more comfortable. There's another kind of glare called veiling glare. Every morning and every evening when I drive to work, I'm driving right into the rising or setting sun. And at that critical angle, the light is so bright that it just blocks out what I can see. Now, veiling glare is not helped by polarized lenses. So there's a type that a polarized lens does you no good. And then finally, what you're all experiencing in macular degeneration and some of the other eye pathologies is called scattering glare. Scattering glare is light comes in, hits a surface, and goes all different directions. And any of you who live in the north where we get snow and things like that, when all that gunk gets on your windshield and headlights hit it, it scatters everywhere. Or those of you who have cataracts or had cataracts, you may remember how glare bothers. That's scattering glare. That's what's happening in AMD, and polarized lenses don't help that. And the reason I keep going on this polarized lens thing, don't get hung up that you've got to have polarized lenses. In many of the low vision cases, it's really not a benefit. Remember, glare hurts, glare affects function, but actually glare doesn't affect function nearly as much as that contrast loss. So I always try and point out to my patients, my colleagues, other doctors, that this is not a 2020 world we live in. Well, everybody shoots for that as a young eye doctor, but newspaper print is 2050 to 2060. At my local McDonald's, the menu type up there on the wall takes 2080 vision. Grooming requires someplace between 2050 and 2100. But your independence and safety is threatened when it falls below 2060. Now, the reason for this is once you can no longer read without help, if you can't read your mail, your bills, a food package, a medicine bottle, or a bank statement, your level of independence is threatened. And you may have a support system that can help you with that, but I would rather that you could do it yourself. So remember, you may still be driving a car legally in the state that you live in, but still you're suffering that early loss of independence. So optics kind of get involved in this whole thing. And I don't want to give you an optics lecture, but I want to give you a little bit of information that will start to make sense to you when you go to your eye doctor. And you don't have to remember all these things, but just the concept. There's something called the just noticeable difference in the human body. And that's the level of stimulus it takes before the body can respond. If you cross your leg goes to sleep, and I would take a feather and tickle it, you wouldn't feel it. But boy, if I hit it with a 2x4, you would. That's because I gave you a big enough stimulus that you could respond. Well, when they check your eyes with that big machine, the Star Wars machine, looks like it's called a phoropter. The lens increment that they change, which is better, click 1 or click 2, is so small that those of you with any degree of macular degeneration, you can't respond to that stimulus because it's way too small. In the low vision clinic, we don't even use those instruments because they really don't get us to where we want to go. But just keep in mind when the eye doctor is there and he's saying, is it better here or here? The stimulus may not be great enough that you can even respond to it. So when the visual acuity falls below that 2050, 2060 level I was talking about, then a phoropter refraction really gets questionable at best. So I talked about contrast. The second thing is magnify. And the reality is, think about macular degeneration like a photo camera with a bad roll of film. No matter how carefully I focus the lens, the roll of film would prevent a sharper, crisper, clearer, wonderful picture. So all we can do at that point is enlarge, magnify things big enough that even with your less than perfect vision, you can identify what's there, that you can use that magnified image to make some decisions. So the next step is what I call matching the tool with the goal. Remember, we talked about very specific goals that you had to set for yourself. So now we've got to match the tool. And your goal and your level of vision dictates what my choices and your choices will be going forward. For instance, if the primary goal is spot reading, just mild reading, and your visual acuity is better than 2150, boy, I've got a lot of choices. I've got tons of choices, from little optical magnifiers to sophisticated electronic magnifiers. The same goal of just spot reading, but now the vision's 2200 to 2400. My options, and thus your options, are getting more and more limited. And then when we get to 2400, the range becomes even narrower. Sometimes I get patients in where, honest to goodness, optical magnification or video magnification is not realistic, that they need to function on a more auditory level. So I want you to all think about low vision aids kind of like a tool for a handyman. You know, drills don't saw boards and saws don't make very good hammers. It's common for a patient after they've had an established relationship in a low vision clinic to require more than one device. In fact, where I trained at the New York Lighthouse, the average patient had 3, 4, 5 different low vision aids. So again, it's very, very common that you're going to need more than one aid. None of these things are like Swiss Army knives. They don't do everything. So I have a slide, unfortunately you can't see it, of examples of low vision aids. And they can be as simple as something that looks like a paperweight, a little paperweight magnifier, all the way up to sophisticated electronic devices. I have one that we've got a prototype of that looks kind of like Star Trek, where you wear these things. But keep in mind, none of them are magic. They're just tools, and the appropriate tool for you may be very simple. The options we have may be a little bit more sophisticated. I never give a talk about low vision with a group like yours without talking at least a bit about driving in low vision. And you need to research your state's requirements. Now, if you're geographically challenged, I have my clinic right between Missouri and Illinois, and the driving laws could not be more different. In the state of Missouri, if your vision corrects to 20/40 or better, you have an unrestricted license, daytime, nighttime, anytime. Worse than 20/40, but better than 20/70, daylight only. Worse than 20/70, but better than 21/20, daylight only, and only on local roads, 45 miles an hour is what they say. And then finally, 21/20 to 21/60, daylight only, 45, 10-mile radius of your home. So it's called a progressive restriction law. Yet over in Illinois, it's unrestricted 20/40, 20/40 to 20/60, daylight only, 20/60 to 2100, possibly with a bioptic telescope. That's a pair of glasses with a miniature telescope. Possibly we can keep you driving with that. So research your own state's requirements. And I suggest you go to the website where they have all of them, because your eye doctor may not know what the restrictions are. I tell you that in a training institution where we train new ophthalmologists. Every year I have to tell them what it is. Be realistic. I always say that there are 3 variables that we have to think about when you're talking about driving. The first one is, what does the state law say? If we can't meet that, it's over. The second one is, with your level of vision, if you meet the state requirement, are you confident you can still drive? Because if I can't improve your vision, but it is legal, do you feel it? And then the third thing is, what does a passenger think of your driving ability? My 21-year-old daughter has 20/20 vision, and I'm scared to death. She won't be a good driver if she gets AMD in the future. So again, think about law, confidence, and then a third person. You may have some options. If you can drive legally in your state, be honest with yourself about putting personal limitations on it. For instance, studies show that driving in daylight is better for most patients with vision loss. So daylight hours. Number 2, non-rush hour times. The city I live in, believe me, between about 7:30 in the morning and 9:30 in the morning and 4:30 in the afternoon to 5:30, it's like a death race out there. What I call good vision conditions, not rainy days, not snowy days, not overcast days. And then really limit yourself to familiar areas. If you know where the left turn arrows are and that you can always get to where you're going by making right turns, or whatever your system is, you're going to have less issues than going in unfamiliar areas. So I'm going to start wrapping this up with some random thoughts that I have. The first one probably doesn't sound like it should be coming from an eye doctor, and that's what I call the 5 stages of grief. Some of you may have read this at some point in your life. When you have a significant loss, it's very common to go through these stages. One's denial, and that's the patient who realizes their vision's declining but puts off that visit to the eye doctor. And then they go to the eye doctor and they're angry and they don't believe this guy, so they go to another guy and they keep getting the same answer. And there's a stage called bargaining, and then depression. And very often when I get a patient in and they're either in the angry or the depression stage, it's very difficult for me to do anything that's positive for them. I may be able to identify things that I can help, but it isn't good enough for them. And then the final stage is acceptance, and that is, I'll do whatever it takes to be able to, you fill in the blanks what I want to do. So be aware that your emotions apply to your visual status. The next thing is, going forward's up to you. Like most things, early intervention is very important. If I can get somebody in here where they first are diagnosed with age-related macular degeneration and they're doing pretty well, then boy, oh boy, it's quite easy to help these people if they're willing to take the help. I'll tell you a quick story, and I'm not sure it applies here, but it's kind of a funny story. 25 years ago, I had a little lady come in, her first name was Rita, and she had macular degeneration, actually a significant amount. And I showed her somehow that she could read her mail. I've forgotten what it was. She said, you know, I'm 85 years old. I'm not going to do this. I haven't got that many more years. Well, lo and behold, a year later, Rita's back in my clinic again, and she had kind of salty language, and she said, give me that, you know what, magnifier and show it to me. And I did. And about every year or two, Rita would come back, and because some types of macular degeneration are progressive, we'd have to change things a little bit. She came in until she was over 100 years old. And the funny thing is, by the way, we kept her reading all that time by making these changes. But the funny thing was, at 100, she said, you know, next time I come down here, I've got to get somebody else to drive. And I looked at her chart, and my God, she was like 2,400 by this point. I said, Rita, you're not still driving? She said, no, I'm not, but my daughter's getting a little too old to drive down here. So again, you know, early intervention, little steps, keeps a person going for a long time. One of the things that I don't like saying this, but I think it's important, and that's, there are no magic glasses. You know, you can go and seek new glasses, but don't, if you truly got macular degeneration, if you got that concept of just noticeable difference, as the acuity goes down, the probability of new glasses making a big improvement probably goes down too. What are the toughest goals you'll set for me or any other provider? They involve magnification and a long working distance and a wide field of view. And what would that be? Sheet music. You know, I want to be able to play the piano or organ again. Card games. I love to play bridge, but you've got to be able to see the whole hand. And if you can't see it when it's laying on the table, I have to magnify. And if I magnify, there's no way to magnify without reducing the field of view. And then another one is artistic painting. That again is a problem. So be clear that in the best low vision clinic in the United States or in the world, we don't make things sharper, crisper, clearer. We make them big enough that you can function. I suggest if you do a low vision consult, bring along what I call real world materials to show me or show your doctor what your goals and problems are. I've never had anyone come in and say, by golly, all I want to be able to do is read the bottom line of your little handheld eye chart. You know, they want to be able to read their mail or their religious materials or whatever. Watch out for self-prescribing. It's the way the world is today. Everything's available on Amazon and eBay and things like that. It rarely works well. You know, I've been doing this well over 40 years, and I scratch my head to come up with the right solution. And the idea that somebody can just get on and look at what looks shiny and cool and fits into their budget is probably not a good way to do it. Unfortunately, Medicare and most private insurers do not pay for low vision aids. I don't understand why, but they don't. If any of you are politically active and you can put a bug in somebody's ear, it would be great. It always aggravates me when I get these robocalls trying to get me to get a back brace and a wrist brace and a this and a that. And durable medical devices like scooters and things, yet they won't pay for a simple magnifier for my AMD patients to maintain their independence in their home. So where are you going to go? your eye doctor should, and I'm emphasizing should, be able to help you find a low vision provider in your area. Don't be disappointed if they don't, but they should be able to. Other possibilities, every state has a commission or a bureau for the blind and visually impaired, and they contract with people like me to do low vision evaluations. So they should be able to at least tell you somebody in your area. Every state has an optometry or ophthalmology society or association, and they should have a list of people that do. And then don't be afraid to go on the internet. The manufacturers of these low vision aids typically have a database because people like me are customers of these various companies, and they can probably hook you up with somebody in their area. So I'm going to give you a couple take-home points, and then I'm going to open it up to questions and answers if I can make this whole thing work with me. As the population ages, the number of low vision patients is going to dramatically increase. You're not going to be alone on this. I'm seeing a vision loss from diabetes really expanding, and I really worry that that's going to be a major problem. Every patient that I meet experiences some emotional stress. Don't overlook it. Sometimes you need counseling to overcome that. Every patient with reduced vision loss has reduced contrast, and I tried to share things with you. There are things that you can do. Your problems will start as early as 20/50 vision. And remember, there's just 3 variables. If we can enhance contrast, if we can make the image big enough, and the patient's willing to use different devices and things, typically everybody goes well. And my final point is quoting, I think it's Albert Einstein that said, if you continue to do the same thing over and over again, you'll have the same result, and that's the definition of insanity. So I'm going to close at that point. I'm going to see if I can, let's see, exit, minimize video, and I'm going to go to more, and questions and answers. Okay. So the question is, I was diagnosed with wet AMD in both eyes suddenly 6 months ago. I'm getting injections. The biggest challenge is computer work, although I'm having other issues, of course. I'm seeing a low vision specialist tomorrow for the first time, hopefully to get computer glasses and suggestions for options that can help me. Should I bring my records from my retina specialist or last ophthalmologist visit? That was a prior diagnosis. Okay, so the more background information we have, the better it is. So I will tell you that seeing records from previous eye doctors is helpful for me. When we think about a computer, there's multiple ways to approach this. I'm going to use one example of your television. The bigger the screen, the more magnified the image. The more magnified the image, probably the easier it is to see. So I do have low vision patients that will use their computer gurus, and they'll hook up their television to their computer, and the television monitor becomes their computer screen. There are specific softwares that are meant for AMD patients, for visually challenged patients. So there are multiple softwares that your low vision specialist can help you with. And in some cases, we can come up with a pair of glasses specifically for computer use. So there are options out there for you. So we'll go with that. Which doctor should I be seeing? Well, everybody has a role. I tell you, here at St. Louis U, we have retina specialists, glaucoma specialists, cornea specialists, cataract specialists, contact lens specialists, low vision specialists. So don't stop seeing either your retina specialist or your primary care ophthalmologist, because they're doing everything they can to manage your underlying pathology and make sure that things are kept under control. But then the next step is, okay, I have vision decline, what do I do now? And that's probably where a low vision specialist could probably help you. Does insurance pay for low vision products? No, it doesn't, unfortunately. there may be exceptions across this wide land of ours where there may be a private insurer that does, but it's very rare. The next one is I'm having trouble with night driving. Are there glasses that can help? Realistically, don't expect any of these night driving glasses to give you any real benefit. If most low vision patients see best in daylight and don't see well at night. But the glasses you'll see on the internet for night driving really don't. I'm noticing I'm having trouble with colors. Is this because of contrast/low vision? As AMD develops, color perception does go down. It gets muted, and that's unfortunately one of the things that goes along with it. And it has, to some degree, contrast loss. You know, these lenses that I was talking about with these special colors for low vision, they actually distort colors, but they do it in a constructive way. If you have the right color of low vision glasses and you look at a turn arrow, it may not look the same color of green, but it really stands out from the background. Okay, how do I find a low vision rehabilitation clinic in my area? As I mentioned, the first place that I always recommend people start with your eye doctor. They should know someone that they trust in their area. If you don't get any place there, then your state has a commission for the blind. That would be someone I'd consult. Local or it would be statewide optometry ophthalmology societies. And then finally, the manufacturers do have a database of their customers, which they could do. And for instance, one of them that I'm very familiar with has a website, and if you ask them, can you give me the names of 5 people in my general area that do low vision care, they will. Where can I find products that help me to live in my home? Okay, so in the low vision world, there are what I call non-optical products. Remember I described that plate that half is black, half's white. Those are considered non-optical low vision aids. And honestly, the way the world is today, I don't think you're going to find a store that has them unless you're in a, like Sun City or someplace like that. But I think that probably on the internet, if you just would Google non-optical low vision aids, you may be able to find something. Okay, my most recent eyeglass prescription says right eye 20/60, left eye 20/50. That is your visual acuity. So you're at that critical point. You're what I call in the transition stage from regular glasses being helpful to early low vision aids. I love cooking, boy, so do I. And notice that I'm having trouble with knives and my stove settings. Is there anything that can be done? Yes, there is something. We like to combine visual and tactile feedback. And there are some non-optical devices. They almost look like little braille markers that you can put on a stove. My wife taught me that if I can heat the stove up to 350, then I can heat up the dinner we're supposed to have that night. And there are things, these again get into that non-optical low vision aids. And of course there are certainly really cool, sophisticated low vision aids that look somewhat like a smartphone. By the way, I'm leaving that out. You could take your smartphone and use that as a magnifier for very short things like looking at stove settings. I'm not sure about the trouble with knives, so I'm going to skip on that. I have macular degeneration. My eye doctor says there's nothing that he can do. What should I be doing? Okay, now, early on I said there's nothing to do to fix the underlying problem, okay? Horrible example. A man's in a bad accident, loses the leg at the knee, and the orthopedic surgeon says there's nothing more I can do. Well, that's not true. Somebody can fit him with a prosthesis or crutches or a motorized wheelchair. Same thing for you. Just because he can't fix it doesn't mean that you can't take what's there and function better. Can't make it like the old days, but we can certainly make it less bad than what you're doing. So what does a low vision clinic do? Wow, pretty much what I described today. We take the vision that you come in with, we take the goal that you have, and we try and match those two together. Can you lay out again what specifically we should ask for in a new sunglass lens and what we should say we don't want in that lens? If you've got age-related macular degeneration, this is, by the way, there's a little bit more to it than me saying the magic color for you. However, if I was going to say just generally what would work better for you, if you've always had gray or green lenses in the past, I'd switch to brown. The typical colors I work with in the low vision clinic that then goes to my optical, though, is more in the orange and dark ambers for sunglasses. Okay, can you lay it against, okay, where am I located? Do you want a serious answer or a joking answer? I'm in an anonymous office someplace. I'm in St. Louis, Missouri. And I use wraparound. This is a question. I use wraparound, which block out 100% UVA, UVA. They're hazelnut, orange, and lemon, depending on the bright sun. Should they be polarized? Not necessarily. I don't think there's a big benefit unless you're a boater or around water a lot. Okay. I have geographic atrophy, second to dry AMD. Should I add? It just means that the size of the affected area in your retina is a little bit larger, but that's typically that. And what is on the horizon that you know of that could be a game changer, if anything? Okay, now, when the Titanic sunk, the people that got into the rescue boats, what few life rafts and rescue boats were there when I think it was the Carpathian showed up the next day and picked them up. So when I talk about the game changer, I'm encouraging you to get in the rescue boat, which is the low vision clinic, rather than waiting for the ship to come. There are studies going on right now for treatments for dry macular degeneration, somewhat similar to what's used for wet. So that's going to be, I don't know, a game changer, but it's certainly going to influence it. So there's always new stuff, but don't wait for the miracle cure. What you need to do right now is do something. Don't sit back day after day after day saying, one of these days they're going to have this magic solution for me. And I don't see any more questions. Larry, are you there?
That's it. Okay, I want to thank Dr. Porter. One thing I might add that you didn't mention was the use of occupational therapists. Because I remember when my mother had her vision problems, the OT enabled her to cook and do a lot of things in the house that she couldn't otherwise do. And that's often covered by insurance.
That's a great point. So Medicare and most private insurers pay for services. Like if you come to me, it pays for any and all office calls necessary to help you out. We have a team of people that we work with in our clinic, and one of them is an occupational therapist, and we, like Larry said, we send them out to the home to actually take the plans that we've put in place and implement the plans. Very important person.
Good. Well, I want to remind everybody, thank you for attending. This was a very interesting discussion today. Please visit our website, which is called macularhope.org, to see future webinars related to vision issues. Dr. Porter, thank you very much.
Thank you. I appreciate it. I'm sorry about the technical problems.
That's all right. Worked out fine. Have a good day, everybody.